Hello everyone and welcome to our module on cellular adaptations. The cells in our body are often exposed to a stressor. A stressor could be something pathologic like ischemia or maybe heat or maybe an infection, or a stressor could be something physiologic. For example, when a woman becomes pregnant, the baby begins to grow and that changes hemodynamics, that adds a new structure in the abdomen. So that's another example of a stressor, although it's not a disease state. When cells are exposed to these stressors, they can adapt. This is that they undergo a reversible change in response to stress. The cell will try to change itself to give it a better chance at survival in an environment with that stressor. Now, there's only a limited ability of cells to adapt, so if the stressor is too great, eventually the cell will become injured. And in another video, I talk about reversible and irreversible forms of cellular injury. And then finally, cells can die if a stressor is too strong or overwhelms the ability of the cell to adapt. We're going to talk about the four main types of cellular adaptations in this video. The first one is hypertrophy. That's an increase in the size of the cell. The second adaptation is hyperplasia. That's an increase in the number of cells in a tissue bed. And this often occurs together with hypertrophy. Many stressors lead to both hyperplasia and hypertrophy. We'll also talk about atrophy, which is a decrease in cell size. And finally, we'll talk about metaplasia, which is a change in the phenotype of a tissue bed. Let's start with hypertrophy. This is an increase in cell size. Cells that undergo hypertrophy synthesize more proteins, more filaments, and they become larger. This often occurs together with hyperplasia, as I said before, but you should be aware that muscle tissues like your heart and the muscles in your arms undergo only hypertrophy. They do not undergo hyperplasia. What this means is when you lift lots of weights, for example, like this man shown on the screen here, you will not increase the number of muscle cells, but the muscle cells you have will get larger. The same is true in the muscle tissue of the heart. When the heart is exposed to increased afterload, it will undergo hypertrophy. In other words, more sarcomeres will be laid down in the cardiac myocytes, but the cardiac myocytes will not divide and increase in number. In other words, they will not undergo hyperplasia. So there are a number of physiologic examples of stressors that lead to hypertrophy. Bodybuilders, like I showed you on the last slide, undergo muscle hypertrophy. The uterus undergoes hypertrophy in pregnancy. This is driven by the hormones of the pregnant state. And then the classic pathologic example of hypertrophy is a cardiology example, left ventricular hypertrophy. So this is a drawing on the screen of a left ventricle that has very thick walls. This is an example of concentric hypertrophy. And this occurs in the left ventricle when people have hypertension or there's an increased workload on the heart. The next cellular adaptation is hyperplasia, which, as I told you before, is an increase in the number of cells in a tissue bed. This occurs in many situations when there's excess hormone stimulation. This is the classic response to hormone stimulation. It can be physiologic or pathologic, and as I told you before, in many cases it is accompanied by hypertrophy, such that cells in a tissue bed exposed to a stress not only increase in number, that's hyperplasia, but they increase in size, that's hypertrophy. Shown on this slide are some physiologic examples of hyperplasia. Breast growth in girls at puberty is due to hyperplasia and hypertrophy of glandular epithelial cells in breast tissue. Your liver, you may know, is capable of regeneration. Some people donate part of their liver to another person. When they do this, the liver grows back to full size, and that's because the remaining hepatocytes undergo hyperplasia. And then finally, your bone marrow is capable of hyperplasia. When there is anemia, there will be hyperplasia of red blood cell precursors, and this can increase the production of red cells. In fact, your bone marrow can increase production by up to 8 times normal if it needs to, and that's due to hyperplasia of red cell precursors. Shown on this slide are some pathologic examples of hyperplasia. One of the classic examples is endometrial hyperplasia, which I talk about in detail in videos in the reproductive section. This is a hormone-driven process. As I told you, hyperplasia often occurs in response to hormone stimulation. In this case, the endometrial lining is growing due to estrogen stimulation. The prostate gland can also undergo hyperplasia. This is also a hormone-driven response. In this case, it's an adaptation to the stressor of excessive response to androgens. And I also talk about this in the reproductive section. And then finally, human papillomavirus can infect your skin or your genitals and cause hyperplasia. It gets into the cell and stimulates cell division. If it gets into the skin, it can cause skin warts, like is shown here. This is due to hyperplasia of the epidermis. If it gets into the genital mucosa, it can cause mucosal hyperplasia, and that leads to genital warts. One of the basic principles of pathology is that anytime you have cells that are rapidly dividing, this can lead to malignancy, and this includes in the setting of hyperplasia. The reason for this is that anytime cells are dividing, they are copying their DNA, and every time they copy their DNA, there's a small chance of an error. If that error leads to a genetic mutation, that gives the cell immortality and allows for uncontrolled cell growth that can lead to malignancy. So that means that in settings where cells are rapidly dividing, including hyperplasia, there is increased cell division, there's more chances for an error in copying DNA that leads to errors in cell cycle control, and this can lead to uncontrolled growth, such as in this patient whose liver is full of tumors here. That person has developed malignancy, which can come from hyperplasia. Earlier, I mentioned that the prostate gland can undergo hyperplasia in response to androgens. This is a pathologic example of hyperplasia. But I want to point out that this is a unique form of hyperplasia in that it is benign and does not lead to malignancy. That's why it's referred to as BPH, or benign prostatic hyperplasia. This is very unusual in that hyperplasia of the prostate gland is not associated with an increased risk for malignancy. The reasons for this are not completely understood. Let's talk about why some cells undergo hypertrophy versus hyperplasia. Certain cells are called permanent or non-dividing cells. The major cells in this category are heart cells like myocytes and skeletal muscle cells and nerves. These cells are in a permanent G0 state of the cell cycle. They're called terminally differentiated. These cells rarely ever divide, and therefore the main response to stress that you see is hypertrophy, especially in the heart and in muscle. Other cells are capable of growth and division even under normal circumstances. For example, epithelial cells have stem cells within the epithelial cell layer that can regenerate lost epithelial cells. You find this in the GI tract, the breast ducts, and the skin. So these cells are normally capable of division, and therefore when faced with a stress, they commonly undergo hyperplasia. And this in many cases leads to dysplasia and cancer. So for this reason, you hardly ever see cancers in the heart or in skeletal muscle, but you commonly see cancers in the GI tract, the breast ducts, and the skin, and that's because these places have cells that are capable of cell division. Those cells often undergo hyperplasia, and as I told you before, hyperplasia can lead to malignancy. Our next cellular adaptation is atrophy. This is a reduction in size of an organ or tissue. It can be due to both a decrease in the size of the cells in that organ or a decrease in the number of cells. There are a bunch of physiologic examples of this. Many embryonic structures in utero, for example the notochord, do not persist into adulthood, and the reason they don't persist is because they undergo atrophy as the fetus is developing. After childbirth, the uterus is going to shrink, and that's because it loses hormone stimulation. So the uterus, therefore, is going to undergo atrophy, and you're going to see a decrease in both the number of cells in the uterus and the size of the cells. And then at menopause, there's a fall in hormone levels in women, and this can lead to shrinking of the breast and uterus, and that is another example of physiologic atrophy. Some pathologic examples of atrophy include unused skeletal muscle. You may know if you don't go to the gym for a while, when you usually do go to the gym often, that your muscles will shrink. That's atrophy. This can be pathologic when patients are on prolonged bed rest or if they have muscle tissue that's immobilized, for example, if they have to wear a cast after a fracture. This can lead to atrophy. And this is a big problem in elderly patients who are hospitalized for a long period of time. When they get out of the hospital, they are often deconditioned and have a lot of trouble doing their daily activities. That's because they've had skeletal muscle atrophy from prolonged bed rest. Cachexia is a form of wasting in the setting of poor nutrition. This is a child from a country that has famine and starvation, and all of his organs and his muscle tissue are undergoing atrophy because of poor nutrition. If there's decreased blood supply to an organ, it can atrophy. One example of this is senile atrophy of the brain. The brains of elderly people are smaller than the brains of younger people. There are many reasons for this, but one of them is believed to be that atherosclerosis leads to decreased blood flow, and that contributes to senile atrophy. And then finally, if there's loss of innervation to a muscle, as occurs in neuromuscular disorders, this can lead to atrophy. This is a big problem for many people with neuromuscular disorders. First of all, they're not using their muscles, and that leads to atrophy, but it's not just that. If the muscle is not properly innervated, it also undergoes atrophy. So let's think about a skeletal muscle cell that's not being used and undergoes atrophy. What is happening on a cellular level that makes that muscle cell shrink? Well, the first thing that's happening is the ubiquitin proteasome pathway is being activated. I talk about this in some of the videos in the cell biology section, but by way of review, ubiquitin is a substance that can be tagged to proteins, and when ubiquitin is attached to a protein, it is transported to the proteasomes and the protein gets degraded. And there are many stressors that have been shown to activate enzymes called ligases that attach ubiquitin to a protein, and this leads to protein breakdown. A second cellular mechanism of atrophy is called autophagy, which means self-eating. Cells have been shown, when exposed to certain stressors, to fuse components of the cell with lysosomes, so they are broken down. It's high yield to remember that these are two of the well-described mechanisms by which cells undergo atrophy. Our next adaptation is metaplasia. This is a change in cell type to adapt to stress. If cells are exposed to stress, in some situations they will change their shape, they will change what they look like, and the new cell type is better able to withstand the stress. This is very common among epithelial cells where they change from one type to another. For example, a squamous epithelial cell becomes a columnar or vice versa. It's potentially reversible. If the stressor is removed, the cell can go back to its original form. However, if the metaplasia persists, this can lead to dysplasia, which we'll talk about in a minute, and malignancy. So just like hyperplasia is often a precursor of malignancy, metaplasia is also commonly a precursor. In metaplasia, you have cells changing their shape. They also are dividing, and there's increased risk for a mutation that leads to uncontrolled growth. So let's go through some clinical examples of metaplasia. A classic one is the respiratory tract in smokers. Normally, your respiratory tract is made up of columnar epithelium, which you find in the trachea and bronchi. But if this epithelium is exposed to smoke, it will change into a squamous epithelium. This is the most common form of metaplasia, is transformation from columnar to squamous cell epithelium. This occurs in many cases, including when your respiratory tract is exposed to smoke. And the reason this is the most common type of metaplasia is because squamous epithelium is much more durable than columnar epithelium. The problem for smokers is that the squamous epithelium does not have cilia, so now they are more vulnerable to infections, and this is one of the many reasons that smoking is bad. In addition, you may know that many smokers develop squamous cell carcinoma, and that's because their respiratory tract has transformed due to metaplasia. And this is a picture on the bottom to help you remember. This is what the respiratory tract should look like, but it starts to look like this when it is exposed to cigarette smoke. Another classic example of metaplasia is Barrett's esophagus, which I talk about in detail in videos in the GI section. When gastric acid gets into the esophagus, it is a stressor, and it transforms the normal esophageal mucosa, which is stratified squamous epithelium, into columnar epithelium, similar to the epithelium of the intestines. This is an example of it on the screen here. On the right side of the screen is what the esophageal mucosa should look like, and on the left side of the screen is what it's transforming into. And I talk about this in great detail in the GI section. Another example of metaplasia is myositis ossificans. It's also referred to as heterotopic ossification. In this form of metaplasia, muscle tissue turns into bone, and this is an important example of metaplasia because it does not involve epithelial cells, and that makes it relatively unusual. Muscle and bone are both examples of mesenchymal cells, and in this situation, one type of cell, muscles, turns into another bone and forms osteoblastic tissue, and this tissue will lay down lamellar bone inside of muscles. This classically occurs following trauma, for example, hip arthroplasty. The muscle around the joint that is repaired and undergoes surgery will become stiff, and this can lead to problems for the patient. And shown on the screen is an x-ray from a person who has had surgery. You can see the screw, and the muscle tissue here has white puffy clouds in it. That is an example of myositis ossificans. Another clinical example of metaplasia is vitamin A deficiency. Vitamin A is very important for maintaining epithelial cells, and as we just discussed, epithelial cells are the type of cells that most commonly undergo metaplasia. In the vitamin A deficient state, epithelial metaplasia can occur and keratinization of the epithelium can occur. This means increased content of keratin and thickening of the epithelial layer. In the upper respiratory tract in vitamin A deficiency, you can see epithelial metaplasia, where the normal epithelium is replaced by keratinizing squamous cells. This will lead to an abnormal epithelium that has difficulty clearing secretions and resisting bacteria, and that can lead to recurrent pulmonary infections. In the eyes, patients who are vitamin A deficient often develop xerophthalmia, which means dry eyes. This is because the normal epithelium in the eyes secretes mucus, but when that epithelium is replaced because of metaplasia to keratinized epithelial cells, they don't make normal mucus, and therefore the eyes become dry. And then a final example of metaplasia is apocrine metaplasia. I talk about this in the breast videos in the reproductive section. This is a form of fibrocystic breast change. It's also called benign epithelial alteration because it is a benign condition that does not lead to breast cancer. In this form of metaplasia, there are alterations to the normal lobular epithelial cells, and they begin to look like apocrine or glandular cells. Basically, they begin to look like sweat glands. They develop an enlarged appearance with eosinophilic staining, and this is called apocrine metaplasia. And just like I told you before, that prosthetic hyperplasia is special in that it's a form of hyperplasia that does not lead to malignancy. Apocrine metaplasia is also special in that it is a form of metaplasia that does not lead to dysplasia and cancer. Most forms of metaplasia, just like most forms of hyperplasia, are associated with increased risk for malignancy, Apocrine metaplasia is unique, and the reasons for this are not well understood. I'll finish by talking about dysplasia, which is disordered cellular proliferation. So this is cell growth, just like hyperplasia or metaplasia, but it's disordered. In hyperplasia, cells increase in number, but they maintain the normal cellular architecture. In metaplasia, cells shift from one type to another, but again, they maintain the normal tissue architecture. In dysplasia, the cells are disorderly and they lose the normal tissue architecture. This is a non-neoplastic condition, but it can be precancerous. Patients who have mild dysplasia of a particular tissue may see that dysplasia resolve if the stressor is removed. In contrast, severe dysplasia is often irreversible and leads to cancer. This usually occurs in epithelial cells. It's classically described in epithelial cell layers, and it's usually preceded by hyperplasia or metaplasia. So there's a normal cell as shown at the bottom of the screen. There's some stressor. The cell develops hyperplasia or metaplasia, but if the stressor persists, eventually these transform into dysplasia, which means the patient is getting closer and closer to having cancer. You won't be asked to identify dysplasia under the microscope. This is something pathologists do a 3-year residency to learn how to do. One of the most important things pathologists do is identify and grade dysplasia on biopsies, but you should be familiar with some of the cellular changes that indicate dysplasia. The first one is pleomorphism, so cells and their nuclei display lots of variability in size and shape when there is dysplasia present. A second change is abnormal nuclei. The nuclei can become very dark, that's hyperchromatic, and they can also enlarge when cells are undergoing dysplasia. And then finally, tissue beds that have dysplasia occurring will demonstrate lots of mitotic figures, which are clumps of chromatin. These are evidence that mitosis is occurring. If you look at the bottom left side of the screen, you can see a dark nucleus that is clumped. That is evidence of a mitotic figure. On the right side of the screen, you can see chromatin that is separating in metaphase. That is also evidence of a mitotic figure. Under normal circumstances, you may see rare mitotic figures, but when you see lots of mitotic figures, that indicates lots of cellular division, and that is evidence of dysplasia. And the classic clinical example of dysplasia is in the cervix. In cervical dysplasia, the normal cervical epithelial layer, which is shown on the left, transforms into dysplastic tissue. Note that the normal layer is nice and orderly with layers of cells. On the right, what you see is that normal architecture has been completely obliterated. The nuclei of the cells show lots of change in shape and darkness. That is evidence of dysplasia. And that concludes our video on cellular adaptations.